Good af Good afternoon, guys. Good afternoon. How you doing? So far, so good. How was your final? It was good. You think the grade did? Oh, okay. Was it hard? So hard. Oh my God. I hope all of you will do well. Okay, so I wanna I wanna start by highly emphasizing that this module I'll be going through some personality change, and I'll be teaching both midchem and pharmacology. Okay? Thank you so much. All right, so just do not forget that, because you're used to me teaching only midchem, only worrying about the structures. Now we have to worry about mechanism of actions, side effects, drug interactions, pharmacokinetics. But I will be very clear on what I expect you to know. Okay. So to start with, for this module, I will not be expecting you to know the spectrum of activity for the antibiotics we'll teach. Why? Because this will be taught and covered by the therapeutic faculty. Okay, so even though you will see that we will talk about the spectrum of activity for these antibiotics, but I'll just go through them quickly. I won't expect you to know that. You will need to know that for the pharmacotherapeutic. Make sense? So I will be asking about, of course, midchem questions as well as mechanism of action, side effects. I will emphasize things that are important throughout the lecture. Okay. So you don't have to memorize all the side effects and all the pharmacokinetics properties, like half-lives, things like that. Only if there is something unique and it's related to some concept, I would expect you to know that. Make sense? So if I forget, or if you see something and you're not sure, are we expected to know this information, just ask me. Okay, I try to focus more on concepts and understanding and relating those concepts to the real life applications for you as pharmacists. Okay, so this is my goal. Questions before we start? No questions? Okay, so today we'll talk about the pharmacology and midchem of antifungals. To start with, just starting with brief introduction and some definitions. So first of all, an infectious disease caused by a fungi would be called mycosis. Okay, and it's often chronic in nature. Most of the fungal infections are actually chronic. We treat them, but they keep coming. Okay, they may be, those infections, mycotic fungal infections, they could be either superficial, okay, or there might be subcutaneous or systemic infections. Okay, and so you would see that antibiotics are given either topically for treating those superficial, or if the infection is subcutaneous or systemic, those antibiotics has to go through systemic routes, like either orally or by IV. Make sense, guys? So, if it's topical, we apply topical antibiotics. If it's systemic or subcutaneous, we have to treat it, through systemic routes. Sometimes we have to treat the fungal infection using both routes. So we'd see combination of drugs. So far, so good? Okay. Characteristics of the fungi are so unique and diverse, and they are classified into the kingdom. We will see their classifications soon, but we're gonna focus on the differences of the structure, the components of the fungi, and how is that important for designing antifungals. Because as you could imagine, when we find certain features in those fungi, can we use that to our advantage? How? By designing something that's more selective and specific to them. Okay? All right, so the first thing we need to know is that unlike bacteria, these fungi are eukaryotic, which means, what's the difference between prokaryotic and eukaryotic? Eukaryotic has a well-defined nucleus, okay? Unlike the prokaryotic, right? They have rigid cell walls. Now we know in bacteria we've seen cell walls. In the case of the fungi, they are more rigid, and they are actually different in their nature and the structure. Remember what's the structure of the cell wall is made of in the bacteria? What was the peptidoglycan? Thank you so much. In the case of the fungi, we have something called chitin. Okay, so these cell walls are made up of chitin. Okay, unlike the case of the peptidoglycan. Another difference is that in the cell membrane, you might remember from your biochemistry how in the cell membrane we have the phospholipids, but we have something else, which is cholesterol. Remember that? In the cell membrane, cholesterol is responsible for the rigidity and stability of those cell membranes. Now, in the case of the fungus, instead of cholesterol, we have something called ergosterol. Okay? Why is this important again? Because we could specifically design something that could affect ergosterol but not cholesterol and avoid side effects. Okay? However, as you will see by end of today's lecture, we'll still have some side effects from drugs that affect cholesterol. Okay? Why? Because if you look at their structures between, the structures between differences between ergosterol and cholesterol, there are some, differences. Okay, but they're not much. So if we don't design drugs specifically targeting the ergosterol, we might hit the cholesterol as well. Okay. And as you might know by what you described so far, drugs that work on bacteria will not work on fungi, and vice versa. Okay, so if you design something, if we have antibiotic for bacteria, it's not going to work for fungi, and if you have a fungi, antifungals do not work for bacteria. So far so good in this introduction. Any questions? Okay, so in short, we have differences between the human cell and the fungi cell, and we highlighted those differences because we're gonna need them, use them to our advantage when you design antifungals. All right. Next, we're gonna talk about the kingdom of these fungi, different types. I'm not gonna bother going through this. You will see how those different species can be affected by different drugs. It's just here like for, I guess, a quick introduction. So we have, for example, yeast, dimorphic, molds, and then yeasts are divided into 3 different kinds. Dimorphic are divided into these kinds, and molds are divided into these examples. Just like for introduction. All right. Next, we're going to talk about the overall mechanisms for the antifungals. Okay. So we have 6 unique mechanisms for those antifungals, and this is something I would expect you to know as a pharmacology concept. So 3 of those 6 mechanisms affect the cell membrane. Okay, 1 of them affects the ergosterol. It binds to the ergosterol, affects the ergosterol in the cell membrane. The other 2 affects also ergosterol, but it affects the synthesis of the ergosterol, as we'll see. So to start with the cell membrane, we've discussed that it has ergosterol instead of cholesterol. Okay, so we have some pathway through which ergosterol is synthesized. It starts with something called squalene, which is converted into lanosterol, and then it's finally converted to the ergosterol. So one way to damage the cell membrane is by preventing the synthesis of ergosterol. How can we do that? As you might guess, we would inhibit the conversion of squalene into lanosterol. There's an enzyme here called squalene synthase. So by designing squalene synthase inhibitors such as terbinafine, niftephine, okay? And there are drugs that inhibit the enzyme here, which is called C14 alpha dimethyl transferase. So you could inhibit this step. Eventually, you prevent the synthesis of ergosterol, which is gonna weaken the cell membrane. Okay? Drugs that affect this enzyme are azoles, which is one of the most commonly used antifungals, as we will see today. So far, so good? Any questions about that? Okay, so far we had 2 drugs that affects the synthesis of the ergosterol, which is important for the cell membrane. Now, the third mechanism is a drug that actually binds to the ergosterol and makes pores, channels, through which the cell will start losing its content and eventually die. Okay, so we have three mechanisms affecting the cell membrane. Those drugs that bind to the ergosterol in the cell membrane are called polyenes. Example on that is the amphotericin and nystatin, as we will see. They bind to the ergosterol and form pores or channels, and so they allow the passage of stuff in and out and damage the cell. Make sense? All right. So that's 3 out of 6. The other 3 mechanisms are, the first one is, remember we said the fungi has a cell wall just like the bacteria. So as you can imagine, we have drugs that target those cell walls. These drugs are called glucan synthase inhibitors, okay, such as the echinocandins. Okay, so these echinocandins, they target the cell wall and they prevent the synthesis of the cell wall. Just like in bacteria, we have beta-lactams targeting the cell wall synthesis. Okay, that's very similar. The last 2 mechanisms, one of them affects the microtubule system, the other binds to the DNA. Now, what's the importance of the microtubule system? Do you remember that from your basic biology? What's the importance of the microtubule system? You guys remember the cell division, meiosis, mitosis? At some stage, those microtubules are important for the division and the separation of the cell. If you block them, then you inhibit the division of that cell. Okay? And so we have drugs that inhibit this microtubule system, such as griseofulvin. All right? And then finally, the 6th mechanism is flow-cytosine, which binds to the DNA. You guys heard of flow-cytosine before? Okay, so you've heard of cytosine, right? One of the nucleic acid components, cytosine, right? So this one, flow-cytosine, mimics cytosine, and so it fools the cell by getting inserted into the DNA synthesis or the RNA synthesis, and then it acts as a false substrate. So by being inserted into the DNA or RNA synthesis, it blocks the continuation of the synthesis of the DNA. Okay, this mechanism is called false substrate inhibition. Okay, so far so good. Questions? Questions? Yes. I have to double check on that. It does get involved in, I believe it's the DNA. I have to double check on that. It does get involved the synthesis of the one of these 2. All right, let's zoom into this thing here, which is glucan synthase inhibitor, and check the next slide. So here are the same mechanisms again, but we're going to focus a little bit on the cell wall synthesis inhibitors. There is something called beta-glucans, okay, which are part of the chitin, which is responsible for the cell wall. And so there's an enzyme called B-glucan synthase. If we inhibit that, then you won't have these beta-glucans, and then you would break the synthesis of the cell wall. Okay, so this drug is these class of drugs are called echinocandins. Okay, and then this, just again maybe review to the other mechanisms as well. This is the example of the polyenes, amphotericin and nystatin that we talked about here. They bind to the ergosterol in the membrane, and they form channels, okay, through which the ingredients of the cell would be lost and cause damage of the cell. And then again, this is the drugs that inhibit the synthesis of the ergosterol. Of course, the flow-cytosine acts on the DNA inside. And what else? We're missing one. I think we're missing one. Let's see. 1, 2, 3, 4, 5. Oh, the griseofulvin, the one that acts on the microtubules, is not listed in the second slide, I believe. I didn't see it. Okay. So far, so good with the overall mechanisms. Any questions? Yes. Yes. So the question was about the beta glucans. This is identical to the peptidoglycans needed for the cell wall synthesis of the bacteria. In the case of the fungi, we have beta glucan responsible for synthesis of the chitins. And so if we block synthesis of the beta glucan, we block the synthesis of the cell wall, which cause damage of the fungi. Okay. So far, so good. All right. Now, here are the mechanisms again, the 6 mechanisms, and then there are, which we're going to talk about today, and there are some other miscellaneous mechanisms we'll talk about at the end of today's lecture. Oh, by the way, so originally we had this lecture as 3 hours, but then we were, because we had to give 1 hour to Dr. Kusumano. Okay, I'm not sure if I'm saying her name correctly, sorry. So I'm gonna be lecturing those 2 hours, and then there will be 1 hour of recording that I'm gonna post on Brightspace. Unless we move like fast, I'm not pushing it, but if we finish today, that would be great. If we don't finish within those 2 hours, then there will be, besides those 2 hours, will be 1 hour of recording that I'm gonna post on Brightspace. Make sense? So today I will lecture from 1 until 3, and then the next Dr. Kusumano is going to be here between 3 to 4. Make sense? All right, since I remembered. Okay, so these are the same drugs listed again by their mechanism of action. There is another classification of these antifungals, which is by their, I guess, whether they act like superficially or on the subcutaneous and systemic. Remember, initially we said those antifungals or the fungal infections could be superficial infections, or they could be subcutaneous and systemic. And so we have drugs that act on the systemic and others that act on the cutaneous. Okay, cutaneous, this is the list. Subcutaneous and systemic, this is the list. Honestly, I don't expect you to memorize which category each one belongs in here, so you don't have to memorize, I guess, which under each one. It's just the concept that those antifungals could be acting either, topically or subcutaneous and systemic. Okay. Let's see. Here are some examples of the cutaneous mycosis. We agreed mycosis means fungal infection, so these are examples on the cutaneous mycosis. Let's see, things like dermatophytes or tinea. So these are the fungus that causes the infection. Tinea infections are classified affected sites. So of course, depending on the site, they could be defined. So the tinea pedis, for example, affects the feet. And then we have como dermatomycosis. These are tough names. Ringworms, 3 different fungi. Let's just skip this slide, because I'm not good with pronouncing names. All right. So another classification of those antifungals, this is my favorite slide. Another classification of antifungals is by their chemical structure. Okay, so we'd see, for example, under antibiotics. So antibiotics mean that they're originally naturally discovered from like other organisms. Just like penicillins were discovered by the penicillin, whatever that fungal is. So some antibiotics were actually discovered from natural organisms. So these are called antibiotics. Anyway, so examples on these are polyenes. If you look at the structure, okay, there's lots of enes, right? That's where the name polyenes, like ene is like the double bond, okay? So we have examples on these polyenes such as nystatin and amphotericin B, okay? And then we have heterocyclic benzofuran, from the structure, hopefully you could recognize it, such as griseofulvine. And then we have the most common antifungal class of drugs are the azoles. Okay, we have two classes of azoles. We have imidazoles and triazoles. So hopefully you could see here in blue, this structures are for the imidazoles and the triazoles. How do we recognize them? So the imidazoles, well, first of all, you want to look for 5-member rings. Okay, so you would look for something like that, 5-member ring. If it has 2 nitrogen, this ring is called imidazole. And so the entire class of drugs that has 2 nitrogens in the 5-member ring will be called imidazole. And then we have triazoles. You would look for the 5-member ring and then see if that, I'm sorry, yes. To the best of my knowledge, it is recording. But in the past, I mean, I see it recording. In the past, I have some problems. So please take notes just in case, okay? Sure. Okay, so in short, those azoles will have a 5-member ring. This 5-member ring is going to have either 2 nitrogen, and then it would be classified as imidazoles, or it would have 3 nitrogens, and they would call it triazoles. I do expect you to classify those drugs just by looking at their structures. This is like would be a bonus question, right? If you just look at the structure, you could look at the 5-member ring, you could categorize it, this is an imidazole or triazole. We will see that these changes in the structure is going to affect their solubility. So generally, there are some exceptions, but generally speaking, if you have a triazole, it's going to have 3 nitrogens compared to imidazole. Which one do you think would be more oral soluble? The one that has 3 nitrogen or with 2 nitrogen? 3. Why? Because it's able to make more hydrogen bonds interactions, polar interactions with the water. Okay? But there are exceptions. Okay? All right. And then we also have allyl amines such as terbinafine. So allyl amine. Okay? We have anti-metabolites such as flucytosine. I don't see the structure here. Yes. So this is going to look like the cytosine nucleic acid, okay? And then we have echinocandins such as, I don't have the structure for that either, okay? And then there are other exceptions such as tolnaftate. So I think the most important structures that I expect you to see and recognize, honestly, are the azoles here in blue and the polyenes. Because it has to, especially for the polyenes, it has to do with their mechanism of action. You will see what's the advantage of having this part of the molecule looking like that. Okay? So if you do see any of these two structures, nystatin or amphotericin B, I do expect you to know the structure and their mechanism of action. I mean, I don't expect you to memorize to differentiate between the amphotericin and nystatin. You don't have to differentiate between them, but I just want you to see the structures of those polyenes and recognize their mechanism of action. Make sense? Because soon we're going to see that this structure is related to the mechanism of action. Okay? Question here in the back. I said something about the azoles. Yes? Yes, triazole, because it has 3 nitrogens. Those molecules generally are more water soluble. Okay? Any other questions? So far so good? Okay, so the first, let's check. So the first ones we're going to talk about are the polyenes. Okay? The first example is amphotericin B. So first of all, let's look at its mechanism of action. I think we're going to talk about mechanism of action next. I'm going to skip to that. So looking at the structure of polyenes, okay, we said that those bind to the ergostrol in the membrane and form channels. Okay? If you look at the cell membrane here, okay, you would see that these parts here in blue are the amphotericin B, and these molecules here are the ergostrol. Okay? Now, can you guess how is the polyenes going to be align themselves to form the channel based on this information? So we've seen the structure of the polyenes in general, okay? Can you guess how the amphotericin or these polyenes are gonna align themselves to form the channel in the cell membrane? Let me, I guess, make the question easier. So the polyenes have two components or two parts. This part here is lipophilic, as you can see, obviously. It's all like hydrocarbons. And this part here is hydrophilic. Okay, so which one of these parts, let's call this hydrophilic, let's call this lipophilic. Which one of these parts will be facing the center of the pore? Which one would be facing the ergostrol? That's easier, right? Yes? The center. Excellent. The hydrophilic is going to be facing the center of the pore, and the lipophilic part is going to be facing or interacting with the ergostrol, facing the lipophilic part of the membrane. Okay? And that's why the water molecules and electrolytes will be able to pass through the center of the pore of the channel, because it's surrounded by those hydrophilic functional groups. Make sense, guys? So if you see the structure of those polyenes, you should be able to tell its mechanism of action immediately, right? Without memorizing, right? Make sense? Okay. All right, let's talk about, continue with the some information about the polyenes. The first one is amphotericin B. It's actually naturally occurring from some fungal called Streptomyces nodosus. So that's why we define it as an antibiotic, okay? Now, one thing you need to know by heart is that those polyenes, they're actually very toxic, okay? They're saved only in case of life-threatening fungal infections, mycosis, okay? Because they're very toxic. They're only saved in the case of the life-threatening infections, okay? You will see, for example, I'm sure in the therapeutics that they will be using azoles and other antifungals, and then they will be saving things like that, such as amphotericin B, to more severe or serious infections, okay? Now, you might think, well, they bind to ergostrol, right? So how is that? They should be selective in theory, right? We do not have ergostrol in our body. So what's going on? How do they become so toxic? Anybody want to guess? Yes. Excellent. Thank you so much. Because ergostrol looks very similar to cholesterol. Okay. So this amphotericin, I guess, won't be able to differentiate between them, and so it binds to cholesterol and cause damage to our cell membranes. Okay. They should be more selective, but they're not as selective as they should be. Okay? All right. Okay, so we described the mechanism of action. They bind to the ergostrol of the cell membrane. They form channels through which things will be lost. Okay, one of the most famous things is actually potassium. Okay, so the potassium would be lost from the membrane, which helps us with one of the side effects of the amphotericin. So when we lose potassium, what do we get as a side effect? Hypokalemia. Okay, so one of the side effects for this drug, for this class of drugs, is hypokalemia. Okay. All right. Now, something interesting we will see later at the end of this class. Because they form these pores, they allow the passage of other antibiotics easily. And so this is going to give us something called, you've heard of synergistic effect, right? Synergistic effect. So you would see this effect when we talk about the 5-fluorouracil. 5-fluorouracil, the fluorouracil we talked about that binds to the DNA. By forming those pores, if you add 5-fluorouracil, you would see synergistic effect between these two. Just something to keep in mind for later. We're gonna visit it again, but just want to point out now. 5-fluorouracil. Okay, the fluorouracil here we talked about, which is, what is it? Here, fluocytosine. I think I said 5-fluorouracil. I meant fluocytosine. Sorry. Thank you. It's another false substrate that acts the same way, but instead of cytosine, it replaces the uracil. Any questions so far? All right. What else? Okay. So spectrum of activity, as I said, I'm not going to be questioning you on that. It's just something I'm sure you would need to know for the therapeutics, though. This amphotericin could act as fungicidal or fungistatic, depending on its concentration. So obviously, lower concentrations will gonna cause fungistatic effect, but higher concentrations causes fungicidal. One of the things we always look at when we study antibiotics, antifungals, is the mechanism of resistance. So we will look at that as well in today's class. So in the case of the amphotericin B, we would see that the fungal resistance is usually associated with decrease of ergosterol content. So the fungi that have developed resistance usually would have less ergosterol in their cell membrane. Okay, and so the amphotericin will not be able to attack it as much. However, this resistance is not as frequent. It's infrequent, so it's not like clinical significant problem. Okay, we will see that this is not the case with other antifungals. Okay, you would see that with other antifungals, there is some more frequent resistance that we need to take seriously. Pharmacokinetics, as you can tell from the structures of those many polyenes, this molecule is going to be water insoluble. Okay, and that's going to be a problem because we won't be able to administer it orally. Okay, so it's water insoluble. It cannot be taken orally. It has to be taken by IV administration. It can also be given topically, but the most common route of administration is IV. Now, if we give it by IV as it is, it causes a lot of problems. Well, it's still going to have problems dissolving in the bodily fluids, and it's going to cause problems at the site of the injection. And so the ideal way of administering this drug is by providing it with some lipid carriers, such as, for example, liposome. We will talk about the 3 mechanisms of formulating this drug into the lipid carriers. Let's see. So these liposome or lipid carriers, they also have the advantage of reducing the renal and infusion toxicity. So the drug by itself, if it's not developed in those lipid carriers, it can cause renal toxicity and infusion site toxicity. So when you administer it at the site of the administration, it causes toxicity. So by designing it into this lipid form, you will actually have less of these two effects. Okay. The main problem with those lipid formulations are they're actually very expensive. Okay. So I mean, you should have a good, really good insurance if you. And then one way to avoid those effects is by administering it slowly. As you're giving it by IV infusion, you would administer it slowly, so you're actually diluting the amount of the drug as you insert it into the body. Okay. Any questions about pharmacokinetics? So far, so good. Okay. Now, other features. For example. So, like I said, I do not expect you to memorize half-lives, protein bound, but just want you to relate these to the concepts. So, amphotericin B binds 90% of the drug binds to plasma protein. How is that going to affect its duration of action? What do you guys think? It's going to make it long duration of action. So, remember one of the concepts, one of the ways to increase the mechanism, the duration of action is by designing it in a way to make it lipophilic. So it binds to these lipids or fat tissues, and then acts as a depot. These tissues will act as a depot. The same way applies to plasma protein. those drugs are going to bind to plasma protein and stay there for a long amount of time, get and dissociate slowly from the plasma protein, and so we have a long half-life, 15 days, the half-life. So what does that mean? How long is it going to take for the drug to be completely eliminated from the body? 5 times that much, okay? 5 half-lives, which is a lot, right? Okay. So there are small amount of the drug that appears in the urine, and over a long period of time, some would be eliminated by bile. So dose adjustment is not required in patient with hepatic dysfunction. Now there is a concept which is the importance of adjusting the dose if you have hepatic or renal dysfunction. If the drug is primarily metabolized or sometimes eliminated by the liver, then if somebody has hepatic dysfunction, we must adjust the dose. Make sense? The same concept applies to the renal elimination. If the drug is mostly eliminated by the kidney, and if we have a patient who has renal dysfunction, then we must adjust the dose. On the other hand, if something is metabolized, eliminated by the liver, and we have renal dysfunction, would you have to adjust the dose? No. Vice versa. If a drug is primarily eliminated in the kidney, okay, and we have hepatic dysfunction, we won't have to worry about adjusting those. Make sense, guys? It should make sense because, you know, whatever organ is responsible for metabolism or elimination, if that organ is damaged, we should increase the dose or reduce it? Reduce it, okay? All right. So in this case, because small amount of the drug is metabolized, and excreted in the bile, then we don't need to adjust the dose for hepatic dysfunction. In conventional, when we say conventional amphotericin B, we're referring to the form of amphotericin B that is not formulated in the lipid carriers, okay? Which these are usually unpreferred and they are more toxic. In the conventional amphotericin B, the drug itself might cause renal dysfunction, okay? And in this case, the dose would be cut by 50%. Okay, so you administer the drug, and then causes renal dysfunction. You would administer it again. You have to cut the dose by 50%. Make sense? Questions about that? So far, so good. Okay. Adverse effects. As I said earlier, those polyenes, specifically amphotericin B, they have horrible side effects because apparently they do not differentiate very well between ergosterol and cholesterol. So they cause very bad side effects. They are very toxic, and so those drugs are only reserved for what? Severe fungal infection. Okay. So first of all, the drug itself has a low therapeutic index. Can you give me an example of drugs that has low therapeutic index? Morphine, digoxin, I think you mean digoxin. What else? Levothyroxine, right? What else? So there is actually 5 or 6 that you should memorize by heart because you will need them for NAPLEX, okay? Actually, not just NAPLEX, for the MPGE exam, because you will be expected to know the drugs that have narrow therapeutic index. So just make sure you check them, okay? All right, so amphotericin B has a low therapeutic index, right? If it's given in the conventional formulations, you would give 1.5 milligram per kilogram a day. If it's in the lipid formulations, you could give higher doses because the drug is safer now. As we said, there is less toxicity if the drug is given in the lipid formulations. So the toxic or adverse effects are as follow. Number 1, you would have fever and chills, okay, especially in the first 1 to 3 hours. And so if you have to give this drug, usually you would have to pre-medicate the patient with corticosteroid and antipyretic to help with the fever and chills, okay? That's a good question. So how much before that? I didn't have that information, sorry. Yeah, so just, I guess, The concept is you want to give it before so it works. But roughly speaking, drugs takes between, how long does the drug usually take to work? It's interesting fact actually. For elimination, drugs vary depending on their half-lives. They take different half-lives for different drugs. But for some reason, interesting reason, maybe you want to check that on your own. Most drugs are absorbed within, if you take it orally, I'm speaking orally, how long does that drug take to be absorbed and reach the circulation? You get the effect? Roughly? An average an hour, usually we say between 30 minutes to an hour and a half. Most drugs get absorbed, get to the circulation within 30 minutes to an hour and a half, and that's when you get the effect. So in that would basically answer our question in this case. You want to give these drugs at least with 30 minutes to an hour and a half before you administer the amphotericin. Okay. All right. Another effect is the renal impairment. Okay. So although there is a small amount of the drug excreted in the urine, it's still, as it's being excreted, it could cause damage to the, I guess, kidney cells. And so it's going to affect the glomerular filtration and the renal tubular function. Okay. You would also see a decrease in the creatinine secretion, and of course, it's going to increase in the serum. You also see a loss of potassium, as we said, hypokalemia, and then loss of magnesium. Okay. So renal function usually returns to with discontinuation for the drug. So the good news is that it's not irreversible; it's reversible. So when you stop the administration of the drug, the renal function goes back to normal. Okay. There's something called azotemia, which is accumulation of urea and nitrogens and waste products. So this is one of the side effects of the amphotericin B. It gets, I guess, amplified if the drug is administered with other drugs that cause the same effects, such as cyclosporin, pentamide, vancomycin. Okay. So it should be avoid combining these two together. Oh, it's accumulation of urea, nitrogen molecules, and waste in the body. Okay. So if you have another drug that causes the same thing, then the combination with amphotericin B is going to be bad. You should avoid them. Okay, how do we avoid those nephrotoxic effects? The best way is by using the lipid-based amphotericin B. Okay, so using the lipid carriers, as we will see, there are 3 ways of doing that, 3 ways of formulating the amphotericin. So you could actually do that. Okay. Questions? Okay. And of course, to minimize, another mechanism is to sodium load with infusions of normal saline. So you'd provide normal saline large amounts. Apparently, it should help with the renal toxicity as well. Let's see. Any questions? Okay. We're still talking about the horrible side effects of the amphotericin B. Another side effect is the hypotension. Okay. It's accompanied by the hypokalemia. Okay. And it requires potassium supplement. So, it's something to keep in mind as you administer the IV, like the hypotension. Now, if this patient is also taking something that's affecting the potassium level, such as the digoxin, then it's gonna even affect the potassium even worse. Okay, so this is something to keep in mind for drug-drug interactions. And then we also have thrombophlebitis, okay, which could be alleviated by giving heparin. And the last, I think, oh no, that's the last. Okay, so these are the horrible side effects for the amphotericin B. Any questions about them? So far, so good? Okay. So honestly, I think all of them in this case are important because we talked about each single one and how this could be alleviated or fixed. Usually if there are side effects where we just go through them and they're like common side effects such as nausea, vomiting, I won't bother. But then for these examples, I want you to know all these side effects and everything associated with them, okay? All right, now we talked about how amphotericin B could be designed in the lipid formulation to minimize the renal toxicity and the toxicity on the site of administration. So there are actually 3 different forms or formulations that this drug could be formed. Amphotericin B lipid complex, amphotericin B colloidal dispersion, and liposomal amphotericin B. Let's look at their structures quickly. So just understand mechanisms in general. You don't have to like dig into the details of each one, okay? So just for your information, this is here in green is the amphotericin, okay? In red, we have the lipid particles, okay? And so in the middle, you would have hydrophobic center, and then amphotericin will be interacting with this hydrophobic center, but then this site, which has the double bonds, will be interacting with the lipid. And so they were designed in a way to form these, I guess, discs that could carry the amphotericin. In this particular example, you could have 35% of the amphotericin in this structure. So 35% of this structure will be amphotericin B. So that's the first example. Another one, like similar in concept but different structures, we have something called cholesterol sulfate, which also binds to the amphotericin B in this form. In this case, you could give up to 50% of the amphotericin. Okay, you could have up to 50% of the amphotericin in this structure. And then finally, we have liposome. I'm sure you've learned about liposome before that in the pharmaceutics. So these are like vessels, okay? And then you have in between those vessels, you have the amphotericin B in between them. And as you can tell from the structure, only 10% in this case would be amphotericin B. Okay, so these are the 3 different formulations. Is not much you need to do other than the fact that these are lipid carriers, different ways of administering the amphotericin B. But I do want you to know the advantage of these carriers, which are, first, you're going to have milder acute reaction. They're going to be used in people who have intolerance to the conventional preparations. Okay, conventional means like they don't have the lipid formulations. You're going to have less nephrotoxicity and less anemia. You're gonna be able to deliver the amphotericin B into reticulo endothelial system of the liver and spleen. Somehow it was found that the delivery is even enhanced to these organs. So if you're trying to target these organs for fungal infection, then this would be a good example. And then they could be used in higher doses. As we've seen, the toxic dose was 1.5 for conventional, but with the lipo lipid formulations, it go up to 10 milligrams. Any questions about the formulations? Any questions? Was that clear? Yes. Liposomes. The green. Yes. Oh, I'm sorry. The was it the green? Oh, yes. I'm sorry. I made a mistake. Fat soluble agent, water soluble agent. Oh, I have to check the labeling here because maybe this one I explain better. Amphotericin in the so in this second structure it shows the yellow the amphotericin structure. I guess in this first one it doesn't. I'm sorry, I didn't pay close attention to that, but that's a good catch. Thank you. Any other questions? Okay. Okay, so next we'll talk about another polyene molecule, which is nystatin. We won't talk about much of the mechanism of action, of course, because we already know that. Just by looking at the structure, we can tell what's its mechanism of action. It has almost the same effects, side effects, everything just like amphotericin B. The only thing is, it's not available except in topical formulations. We don't have nystatin given in IV solutions as with the amphotericin. So it's not used systemically. It's only used locally, topically. Okay? Now, someone might say, well, we do have oral agents here. You could take oral nystatin, right? So how do they act? They don't get absorbed into the circulation. They act actually topically, either on the surface of the mouth, or either like at the intestinal lining. Okay, so they never get absorbed. They act topically, locally. Okay, and so we have, for example, oral agents that you could swish and swallow. You've probably seen that nystatin with these magic, what do they call them? Magic formulation, magic mouthwash, right? So these would be treating the oral Naegeli candidiasis, thrush, intestinal infections, vaginal infections, and then topical infections, of course. And then we have, like we said, ointment, cream, powder, tablets. These are one of the things that are available in the buccal forms. You remember the buccal dosage administration route? So you could put them in your mouth and keep them for 4 to 6 hours, and then once you finish, you take another one. So these are basically used to give topical effect, local effect, not systemic. Make sense? Okay, any questions about nystatin? Okay, it's 1:50 now. I think it's good to have a break before we start with the squalene, okay? So let's have 10 minutes break, come back at about 2 o'clock. It's 1:52, so 2:02. All right.
like the kind of interview, so that's why. So I decided not to email you, just to tell you in person.
Okay, no problem.
I'll watch the
Hopefully it's
recording.
recording. Hopefully it's working.
I have many
Review
friends
that
in the
before.
class today who took the
Exactly.
notes, so thank God.
Sure.
Okay, thank you.
Sure. Any questions? Any questions, guys? Any questions? So far so good? Okay, so remember we said we have 6 mechanisms. 3 of them works on the ergostrol. We talked about the ones that binds to ergostrol and forms the channel. Next, we'll talk about the other 2 mechanisms, which are the ones that prevent the synthesis of the ergostrol. Okay, so these are more selective. Okay, as you can imagine, because they rely on 2 different enzymes. One of them is actually more selective than the other because the enzyme is not present in the fungi. So let's look at that. So the first mechanism is the squalene epoxidase inhibitors. Now you might remember here we said that so we have squalene epoxidase inhibitors, and we also have the demethylase inhibitors. They prevent the synthesis of the ergostrol. So we'll talk about this first, and then we'll talk about, those first, and then the azoles next. All right. Okay, so let's dig deeper into the synthesis of the ergostrol through this mechanism. So first of all, we have something called squalene, okay? And using an enzyme called squalene epoxidase, it's converted into this squalene epoxide, and then it's converted further with another enzyme into lanestrol, which is converted by the lanestrol 14 alpha demethylase into this product, which finally give us the ergostrol. So as you can imagine, inhibiting any of these enzymes would prevent the synthesis of ergostrol. We will focus on things that inhibit squalene and things that inhibits the lanestrol 14 alpha demethylase. Okay? We don't have drugs that works here, or it's not mentioned. There's no drugs as far as I know. So the first class are the ones that inhibit squalene. Now, just something to keep in mind. So those enzymes, they're not present in our body except this one here. Okay, so you would see that this class are more selective compared to this class, compared to azoles. Okay, why? Because we don't have this enzyme in our body, but we do have similar enzymes here. So you would see more side effects with the azoles compared to the squalene inhibitors. Make sense? Squalene enzymes inhibitors. Make sense? Okay. So mechanism of action. As we said, it inhibits the squalene epoxidase and prevents the synthesis of ergostrol, which is necessary for the cell membrane so that the fungi, the cell dies. Yet, there is another effect of that. By inhibiting this enzyme, squalene accumulates and causes toxic products and leads to the death of the fungi. Okay? So this mechanism actually has dual effects. It not only prevents synthesis of ergostrol, but by preventing this synthesis, this product here, squalene, would accumulate and cause toxic effect to the fungi cell. Everybody get that? Okay, so that's an important mechanism of action. And then we have drugs that belong to this class. The first one is terbinafine. Okay, most of the information here will be visited by the pharmacotherapeutic faculty, but let's go through them quickly. So it's available orally. It's the drug of choice for treating dermatophyte onychomycosis, which is the fungal infection of the nail. Okay, it's better tolerated as it requires shorter duration of action. Okay, so you don't have to administer drug for a long time. It's more effective than the itraconazole and grisfulvine. Again, this I'm sure you're gonna visit this with the pharmacotherapeutic people. Some therapies require a long treatment of 3 months. Okay, oral terbinafine may also be used for tinea capitis, which is infection of the scalp. And there is a note that says oral antifungal therapy, such as those 3, is used for tinea capitis as well. There is topical terbinafine, 1% gel, cream, and solution that are used for tinea pedis for the foot, tinea corporis, and tinea crutis, which is infection of the groin. And then duration of treatment usually is 1 week, but it depends on the case, I guess. Questions about that? So I'm sure you're gonna elaborate more into this with the pharmacotherapeutic. Elimination metabolites excreted in the urine, okay, which means it's depending on the renal elimination. And there are metabolites, so there's also hepatic metabolism. So like we said, it's available orally and topically. Its bioavailability is only 40%. What does that tell us about the first pass effect? Is that too much or little, or? It's significant. 40% bioavailable of the drug is bioavailable, which means, I mean, 60% is eliminated in the liver. And so if somebody has hepatic dysfunction, what would we consider adjusting the dose in this case? What do you think? Yes? Who says yes? Raise your hand. If you say no, okay, yes wins. Next time. So hepatic dysfunction, if the drug is primarily metabolized by the liver, it means if there's a problem with the liver, then you should adjust the dose. Make sense? So in this case, 40% of the drug makes it to the circulation. What happens with the 60%? It's destroyed by the liver. So if you have problems in the liver, you have to adjust that, okay? It's highly protein bound, just like with amphotericin B, okay? So it's gonna stay longer in the body. Half-life of 200 to 400 hours. It's like, how many days is that? 200, it's like roughly 10 days, 10 or more. So that's close to the half-life of the amphotericin B, right? It's like 10 to 20 days half-life. Why? Because they highly bound to plasma protein. Oral terbinafine is extensively metabolized, as we said, by this enzyme. You didn't have to know the, we didn't specify the isozyme in this case, just, the CYP enzymes excreted mainly in the urine. Should be avoided in people with moderate to severe renal impairment or hepatic, as we explained, because it's eliminated mostly in the renal, metabolized by the liver. If you have problems in either one of these two organs, you would have to avoid these drugs or perform a dose adjustment. Questions about this slide? So far, so good? Okay. Adverse effects, GI disturbances, nausea, diarrhea, vomiting. I mean, there's no vomiting, but the GI disturbances, headache and rash. So these are common effects I really don't pay close attention to unless there's something unique. I would emphasize, then you don't have to memorize these effects. Taste and visual disturbances, I think that would be something interesting to know for terbinafine. If somebody takes this drug and they tell you they taste the food is tasting differently, or they have visual disturbances, then it's important to memorize or know that by heart. So you could actually consult patients with that, okay? They increase the level of serum the hepatic transaminase. Those enzymes are important for measuring the function of the liver. So if you see these enzymes elevated and you perform a blood test, you might think there's something wrong with the liver. But then if you know that they take terbinafine, then you would explain that, you have an explanation, say, well, maybe it's not problems with the liver, it's maybe because of terbinafine. So that's important information to know, okay? Finally, it inhibits this enzyme. You don't have to know the exact CYP enzyme. And so we should be careful for drug-drug interactions. Now, throughout all these antifungals, you would see, especially with the azoles, they interact with those metabolic enzymes, either in a positive or negative way, either inhibit or induce. And so you should always be careful with drug-drug interactions, specifically with the azoles. Make sense, guys? Now, do we have to memorize which drugs interact with which? For my portion of the course, I don't expect you to memorize the names, but I care more about the concept. So you would have to know that, for example, azoles such as ketoconazole prevents those enzymes. If they are combined with something that's metabolized with other drugs that are metabolized by the same enzyme, it's going to have drug interactions. And I expect you to know the effects of the interaction. Are you going to have increase or decrease of the other drugs? Make sense? Okay. Without memorizing the examples, just the concept itself. Clear? Okay. All right. Another two drugs of the same class are niftatin and butenafine. So they all end with, F-I-N-E, just to help you. Terbinafine. They active against these fungi. Niftatin is available in 1% cream. Treatment of these infections. Duration of treatment is usually 2 weeks. Butenafine is active against these fungi, and they're used typically, again, as in a cream for treating tinea infections. I'm sure you're going to visit all that with the therapeutic people. Questions before we move to the next class? Everything is clear about this class? Okay. All right. The next class also interferes with the pathway of the synthesis of ergosterol, but because the enzyme is actually similar to the CYP enzymes, we'll have horrible drug-drug interactions. Okay. And we're also going to see horrible side effects, more side effects than this class, even though they're both within the same pathway of inhibiting the ergosterol synthesis. But this class here, because it affects an enzyme that's similar to enzymes in our body, you're going to see more effects. Okay? All right. So these classes are the azole. We have, of course, they're synthetic, so they're not antibiotic like the amphotericin B and what else? We talked about antibiotic, antifungals, and we said polyenes, and we said grisevolvine, I think, was one of them. Anyway, so they're synthetic antifungals. They have broad spectrum. They could be fungistatic, static, or cidal, just like amphotericin B, depending on the dose. There are two classes, as we said, depending on how many nitrogens are present in the molecule. So if you look at this molecule, search for the 5-member ring, how many nitrogens? There are 2, so that's an example of imidazole. If there is 3, that's an example of triazole. Okay? And so I wouldn't expect you to know which one belongs to which, but I will provide you with the structures, and you should pay close attention to the structure and find whether it's imidazole or triazole. Okay? Although they have the same mechanism of action, but of course, you're going to have different spectrum of activity and different pharmacokinetic and pharmacotherapeutic uses. And generally, imidazoles are used topically. Triazoles, because they have an extra nitrogen, they are more water soluble, so they could be used systemically. But that's general. You will see exceptions for that. Questions about azoles? So far, so good? Okay. All right. So mechanism of action, as we said, they inhibit this enzyme here, CYP14 demethylase, and so they end up preventing the synthesis of the ergosterol, which is important for the cell structure of the fungi. That's the same mechanism we described, and instead of targeting this, with the azoles, we're actually targeting this enzyme. Now, here is what's interesting. This enzyme is actually a kind of a CYP enzyme, the C14 alpha demethylase. This enzyme is basically one of the CYP enzymes. It's similar to the CYP enzyme. And so by inhibiting this enzyme, you will have all the other effects of drug-drug interactions. You're also inhibiting the synthesis of something similar to ergosterol. What is similar to ergosterol in structure? Cholesterol. So you're going to inhibit cholesterol. How is that going to affect us? Keep that in mind. Just keep in mind that because it affects enzymes in our body that are responsible for synthesis of cholesterol, we're going to have less cholesterol synthesized, and you're going to have major effects, side effects because of that, okay? They also inhibit, because of having no cholesterol, it's going to inhibit the cell wall growth. Okay, so this is the point I was looking for. Because they inhibit cholesterol, you're going to see inhibition of the gonadal adrenal steroid synthesis. What's the relationship between cholesterol and the and these adrenal and gonadal hormones. Yes. Thank you so much. Excellent. All these hormones are made from cholesterol. Cholesterol is the starting point for all these hormones. So if you inhibit cholesterol, you're going to have less of these products. Okay, let's look at this graph really quick. I have it somewhere. Okay, so in case you forgot, I'm not sure if we've seen that before or not, because I teach so many, most courses, I can't remember. Sometimes I repeat myself. Okay, cholesterol is the starting point for the synthesis of all these progesterones, cortisones, hydrocortisones, aldosterone, testosterone, estrogen. So all these pathways starts with cholesterol. If you inhibit the cholesterol, you're going to have all these effects. In fact, you would see that one of the therapeutic uses of azoles is to treat Cushing syndrome. What is Cushing syndrome? You have too much cortisone. When you have too much cortisone, one way to prevent the cortisone is cholesterol. Sorry, the cortisone is by inhibiting the synthesis of cholesterol. Just trying to link the applications and the side effects. And so you would see side effects from those azoles related to the fact that you're inhibiting the synthesis of cholesterol. So if we understand the mechanism, it helps us a lot with side effects and some of the therapeutic applications. Okay, any questions so far before we talk about the SAR of the azole? So we described mechanism of action, Now, structure-active relationship, I don't expect you to memorize all of them. If I do want you to use them, I would provide them as an attachment, but just go through them, make sure you understand them. Except there are some few tips that I do want you to know, okay? These are the ones highlighted in green and in blue, okay? So to start with, these molecules have the basic nitrogen, as you could see in all of them, and so they are actually weak basic. Makes sense. At molecular level, the nitrogens bind to the heme component of the cytochrome B450. The enzyme that's being inhibited, as we said, is a cytochrome B450. So you might remember from your biochemistry that cytochrome B450 have the heme component, heme, which is like iron and heme molecule. So these nitrogens are the ones that bind to the heme component. Okay. Now, the most potent antifungal azoles have 2 or 3 aromatic, which makes sense. That's why you will have, 3, 4, or like 2 or 3. At least one of them should have a halogen, such as, fluorine or chlorine. Okay. Now, the substitutions, and this is what I want you to know, I guess, by heart, is the substitutions here at positions 2 and 4 would provide an active product. If you change the substitutions of the fluorine to different positions, the drug become inactive. Fluorine would give you the most potent form, which is why fluconazole is one of the most potent drugs. Make sense? Questions about that? And then finally, in the structures, you would also see these aromatic groups. They would be responsible for mimicking a part of the steroidal part of the squalene. In the mechanisms here, azoles bind to the enzyme. Why? Because we have some aromatic rings here that mimics those aromatic rings, and so the enzyme get confused and get inhibited. And those aromatic rings are affecting the high lipophilicity of the drug. And then finally, because of the presence of these nitrogens, okay, the drug could be formulated in the salt form to enhance its water solubility. You guys might remember when we talk about drugs and we say like morphine sulfate, citalopram chlorine. There is always a combination of the drug and a salt or an ion. Why are we formulating these drugs in this form? Why do we formulate them in this salt forms? Like there's always a drug and there is the ion component, morphine sulfate. Why do we add the sulfate? You guys remember that from your pharmaceutics? Increase water solubility, exactly. If you just administer the free base of the drug, it might not dissolve. But if you formulate it in the ionized form and then combine it with its opposite charge, now you have a salt and now it's more soluble, okay? So most of these drugs, because of their high lipophilicity, they require to be given in the salt form, except fluconazole, because you have so many polar nitrogens and polar components, they could be administered in the free base. Questions about that? Any questions about the SAR? Okay. And then let's talk about resistance. Can you guess the mechanism for resistance for the azoles? I mean, without looking at the slides. So generally speaking, if a drug acts on an enzyme, inhibits it, what would be the mechanism of resistance, the common mechanism of resistance for bacteria or fungi or viruses in general? Thank you so much. Mutation to those enzymes. So that's one of the mechanisms. You could have mutation to this enzyme and then they don't get affected by the drug anymore. Okay, now what other mechanism? Another mechanism is something called efflux pumps. Some of these fungi or bacteria, they develop an efflux mechanism by formulating a pump, transport pump, that kicks the drug out as soon as they get in. Now, this efflux mechanism is actually something that we have in our body as well to identify toxins. Can you give me an example of an efflux protein that's very common and we use it a lot and you see it a lot in the drug interactions? Yes. Thank you so much. PGP, P-glycoprotein. You guys remember the PGP? So PGP is one of the efflux pumps that protects our body from toxins, okay? So bacteria can develop similar pumps to kick out the drug, and that's one of the resistance mechanisms. So I do want you to know, because these are concepts, understanding concepts, you don't memorize, so I do want you to understand these concepts. I want you to know them, okay? And then this sentence is basically saying that for these drugs, azoles, it's actually frequent and common to see resistance. Why? Because they're actually used in prophylaxis in cases when you have, for example, bone marrow transplant or the HIV infection, or in case of the transplants, we administer antibiotics to protect the patient from fungal infection. And so we have to administer those azoles. As a result, we end up having resistant fungi. And so it is a clinically significant thing. Now, we did say that there is another example of a drug that could have resistance, but it was not common, it was not significant. Which drug was that? Huh? Which one? Which drug was, we didn't have significant resistance? Amphotericin B, thank you. I guess she was eating. It's okay. Okay, drug interactions, as we said, most of these drugs have interactions with the CYP enzymes, specifically azole. Why? Because that's the enzyme they bind to. The enzyme they bind to is actually CYP in nature. So they have so many drug interactions. Okay, so they inhibit the CYP3A4. Okay, you don't have to know the exact isozyme, just in general. And so they might actually induce some of the enzymes. So they inhibit some of the enzymes, and then they might induce some other enzymes. And so the result, as you could see, meaning that you could increase or decrease the effect of other drugs, okay? Which could lead, in case of the increase, you could have toxicity. Several azoles, including itraconazole and voriconazole, metabolized by this enzyme and other isozymes. And so concomitant and concomitant co-administration easier of these drugs would result into these effects. And then finally, contraindication, These azoles are actually teratogenic. That's something I want you to know by heart. Very serious. You know, someone like woman is pregnant, you can never give these azoles. Okay, should be avoided in pregnancy. So far so good. Questions? Right, let's look at some of these. So we're talking in general about the resistance mechanism and drug interactions. Now let's look at some specific examples. So starting with fluconazole, for example, if you see the structure, you can tell it's actually a triazole, and it's active against spectrum of activity on yeast and dimorphic fungi. But like I said, these are things that will be covered in pharmacotherapeutics. They do not have role in aspergillosis and whatever that is. It's highly active against these examples. Again, that's all pharmacotherapeutic. We talked about mechanism of resistance in general, used in prophylaxis of these, like bone marrow transplant, as we said earlier, which one of the reasons we develop resistance. Let's see, concomitant, let's see, drug of choice for these diseases. So honestly, there's not much like I guess I worry about in this slide. Okay. And then pharmacokinetics, it's available orally, IV, topically. It has 94% oral bioavailability. And the nice thing, it's not affected by the food or the gastric acid. So if somebody's taking H2 blocker or proton pump inhibitors, it's not gonna affect its absorption. It distributes very well on the body tissues. Half-life, nothing unique about it, just about half an hour. Excreted unchanged in the urine. Side effects: nausea, vomiting, headache, alopecia, skin rash. Hepatic necrosis, or hepatotoxicity is what I really care about as far as adverse effects. So we need to know about the one of the side effects for fluconazole is hepatotoxicity. Okay, and so it should be used with caution in people who have liver dysfunction. There's also teratogenic effects. Okay, and as we explained, because it inhibits synthesis of cholesterol, which leads to the synthesis of all these hormones, you're going to see of other azoles, you're going to see the anti-androgenic effect. There is no anti-androgenic effect and other endocrine effect with the fluconazole, which is a nice thing. So this is an exception. Okay, that's an interesting thing to know. Now they do interfere with enzymes, but to a lesser extent, to a less extent than compared to ketoconazole, for example. Questions? So far so good. Okay. Uses, this is something will be covered with therapeutics and the dosage, I'm sure. You have to memorize dosages, right? No? Oh, that's good. Nice. That's good. I remember some other colleges of pharmacy, they expect people to memorize the exact milligram and how often, and it was really bad. Yeah. Good. You guys are lucky. Yeah, I mean, infectious disease is one of the most difficult courses because of that, because when students have to memorize spectrum of activity, and I know in some courses, students had to actually memorize the dose, exact dose, like this drug is given in this exact amount 2 to 3 times for this specific condition, which was really a lot. I mean, okay. Next drug, itraconazole. Let's see. So it's a triazole. If you see its structure, you can tell. I'm not going to worry about that or that. Available in oral dosage forms. Should be taken with food. I think that would be interesting. Should be taken with food. Unlike with the fluconazole, we said it's not affected by food, right? So you could take it with or without. It's not affected by the acid amount in the stomach. In contrast, solutions, so the tablet, oral capsules should be taken with food, but solutions should be taken on empty stomach. That's interesting. I wonder why. As food decreases absorption. Okay, so the food decreases absorption for the solution, but with the tablet should be taken with food. I don't have an explanation for that, sorry. Okay. Drug will distribute in the tissue, extensively metabolized by the liver. Side effects are very common. Hepatotoxicity, again, they do not inhibit the steroidal hormone synthesis. That's another important example. Just like with the fluconazole, they do not cause the anti-androgenic effect. Okay, so that's an interesting information. They have negative inotropic effect. I believe that's related to, let's see, no, I can't relate it to something, sorry. Okay, let's see. I think that's all for this slide, just hepatotoxicity and the fact that they do not interfere with the steroid hormone synthesis. Okay. Any questions on the itraconazole before we talk about the next one? Okay, I think that's the last one in the azoles, is it? Oh, no, not yet. Okay. Posaconazole, let's see. Spectrum of activity, long half-life, oral, tablet, IV, broad spectrum. Nothing important here. I mean, from our perspective, sorry. I mean, I hate to memorize things, but like you could find these things really quick if you go to any reference, but concepts stick longer in your mind, but memorizations, okay. Side effects, transaminase. So we talked about drugs that also cause hepatic transaminase. I think it'll be interesting to know that this one here, which is posaconazole, causes that, even though the name is, I mean, to me, I haven't seen it much. I'm not sure if it's used maybe in the hospital, but in retail, I haven't seen this drug name at all. Potent inhibition, of course, most of these azoles interfere with the drug, with the CYP enzymes. So the only important thing I see for this drug is the fact that it affects the hepatic transaminase enzyme. And we've seen that with another drug. I can't remember the name of this drug. I think we've seen it. Questions? So far, so good? Okay, and then we have voriconazole. Let's see, broad spectrum, given IV, oral dosage form, used in this invasive asparagus. I'm sure you're gonna have to know that for therapeutics. Invasive candidiasis, and these two other forms, high orally available. Display nonlinear kinetics, which is affected by drug interactions. Okay, you guys remember, you guys heard of the linear kinetics, nonlinear kinetics? Can you give me an example of a drug that has nonlinear kinetics? Huh? Phenytoin, thank you, excellent, wow, good job. So why is this important? Another actually chemical that has nonlinear kinetic is alcohol, okay? So usually, so that's an important concept. So most drugs or chemicals, they are eliminated using linear kinetics. What does that mean? It has a fixed half-life. You have too much of the drug, enzymes act more, right? And so the more drug you have, the more enzymes that act on this drug. Other chemicals such as phenytoin, alcohol, believe it or not, and this example here, which is voriconazole, have nonlinear. What does that mean? We don't have half-lives. We didn't deal with half-lives. The enzymes are saturated, and so we have a fixed amount of a drug that's eliminated. And instead of having a fixed percentage of the drug, like most of the drugs would say, within this half-life, 50% of the drug is eliminated. For the nonlinear kinetics, We don't have fixed percentage, we have fixed amount. Which one is more dangerous? Non-linear. Why? Because the drug can accumulate really quick, right? If as soon as you increase the drug a little bit, you immediately have accumulation and toxic effects, which is why phenytoin is one of the toxic drugs. You should be careful that you give the right dose, don't take too much, too little, and if any of the drugs interact with it, immediately goes into toxic dose, okay? So just, I mean, this is for your own understanding. It's not has to do with like this particular example, but whenever we say nonlinear, it means the drug is eliminated with a fixed amount. So enzymes are saturated, they can only eliminate this much. No matter how much of the drug you have, enzymes are stuck with eliminating only like certain fixed amount of the drug. And so the other amount has to wait for its turn to be eliminated, okay? This applies to phenytoin, alcohol, and, you know, in this example, okay? So whenever we have nonlinear kinetics, we should pay more attention and be more careful with drug interactions, because anything that affects the concentration of this drug, if it increases, you could end up having accumulation quickly of these drugs, okay? Everybody get that, guys? Questions about that? Okay. All right, adverse effects. We have visual auditory hallucinations with the voriconazole. I think that would be interesting to know. Hepatotoxicity. We talked about the azoles in general interfere with the enzymes, CYP enzymes. They could act as an inducer or inhibitor. Inducer and then causes toxicity. That's just, you know, understanding mechanisms or concepts. Significant interactions are with these drugs. You don't have to memorize the drug names. Again, you know, you just have to know understand the concept, okay? We have miconazole, clotrimazole. They're actually unique for being used topically. You would see a lot of topical of these drugs that are used for oral, pharyngeal, vaginal, cutaneous. What else? They're also available in troches or lozenges and buccal forms. Although with the buccal, we always have to worry about, you know, the local irritation. Finally, we have, before we move to the ketoconazole, do you have any questions about what we talked so far? Okay, finally, ketoconazole, broad spectrum, active against these diseases, orally effective, readily absorbed, even though it does not cross blood-brain barrier, highly protein bound. We talked about the side effects in general for these azoles. They prevent the cholesterol synthesis, and so they end up having those side effects we talked about, such as, you know, less steroid, testosterone, and estrogen synthesis. Okay, that's an important fact. I mean, this is in general applies to azoles, but ketoconazole is unique for this feature, okay? We have two other examples that do not have this feature. Which ones? Fluconazole and itraconazole. They do not interfere with the synthesis of these hormones. I want you to know that, guys, okay? Drug interactions. So we talked about how ketoconazoles or azoles in general affect the CYP, but there is another interactions here, which is how ketoconazole and amphotericin B affect each other. So this effect here is actually an antagonistic effect. What does that mean? Well, let me ask you, maybe you'll be able to figure it out by yourself. The question is, we should not give ketoconazole with amphotericin B. I'm going to give you a hint. And it has to do with their mechanism of actions. Their mechanism of actions contradicts each other. Think about the mechanism of action of these two products. Why is it that we shouldn't administer these two drugs together? Or we won't benefit from administering them together? What do you guys think? What's the mechanism of action of the ketoconazole? Or azoles in general? Plaque synthesis of ergosterol. What's the mechanism of action of amphotericin B? binding to ergosterol in the membrane. Do you see the link between them? So if you prevent the synthesis of ergosterol, does it make sense to administer a drug that binds to ergosterol and inhibit it? It doesn't. You see that concept, guys? You got it, everyone? Okay. Any questions about that? Yes. Excellent. Thank you so much. So technically, you cannot give azoles in general with amphotericin B or polyenes. Why? Because you're preventing the synthesis of ergosterol. And so if you give polyenes rely on the presence of these ergosterol, and so there will be no ergosterol there, so it would be useless, okay? So they are contraindicated because you're not getting benefits and you are getting like horrible side effects from the amphotericin B. But generally, you only give a drug as if there is like potentiation, addition, or synergism. You guys remember these definitions? Which in short means there is an enhancement in the activity of the combination, okay? If there is no enhancement, or if there is less, of course, if there is less, you want to combine them. But if there is no advantage of adding a drug, why would you add it, right? You have side effects from the second drug. Make sense? Excellent. No azoles should be combined with the polyenes in general, okay? Because there is a contraindication at the level of the mechanism of action, okay? All right. Let's see. So, of course, the users will be visited by the pharmacotherapeutic people. Let's see. Oh, the Cushing syndrome. Remember when we said Cushing syndrome means increase in the cortisol level? And so ketoconazole specifically targets this, could be used to treat Cushing syndrome. Why? Because it prevents the synthesis of cholesterol. Okay, so which is responsible for giving us, cortisol and all these hormonal drugs. Of course, you're going to have to deal with the side effects from having less of these gonadal hormones and steroid hormones. Okay, all right. So this table is in general. I don't expect you to memorize it, to be honest, just the general or like for your own information kind of thing. So you could compare between which ones have, half-lives or protein binding or which enzymes are responsible. The same for here. I don't expect you to memorize it, just for your own information. Okay. Okay, I think it's a good time to stop here because it's a new topic. And then the rest will be provided through recorded lecture. Okay, so the rest, starting from the echinocandins, will be provided through recorded lecture. Questions? Do you have any questions? Yes. Oh, that's actually a very good question. So we cannot combine polyenes in general with the azole inhibitors. Can we combine polyenes with the squalene epoxide inhibitors? What do you think? Conceptually, we shouldn't. We cannot. Okay. So the short answer is, based on the understanding the mechanism, it would make no sense to do that. Okay, because both squalene epoxide inhibitors and the azoles, they inhibit the synthesis of ergosterol. When you do not have ergosterol, then how would you benefit from adding a polyene which binds with the ergosterol? So that's a good conclusion. Thank you. Maybe I'll use it for the exam. No, just kidding. Yeah, exactly. Yeah, if the same concept applies. Yes. Okay. Other questions? Yes. Yes. So of course, assuming this is working, I'm going to post it on Brightspace, and I'm going to add the recording on the remaining part also on Brightspace in the same location with the echo folder. Okay. Other questions? So far, so good? Okay, will you enjoy your 14 minutes break before Dr. Gusumano comes in? All right, thank you guys. Have a good afternoon.